Welcome back to the deep dive.
Good to be here.
So today we're diving into something, well, something with a really undeniable appeal for a lot of people. That promise of, dramatically enhanced physique, better performance.
Right. Often through anabolic-androgenic steroids, AA.
Exactly, AS. It's this huge pull, the idea you can just accelerate muscle growth, strength gains. It's a powerful draw.
It is powerful, but yeah, like with most things, not powerful.
There's the flip side.
There's the flip side. The stark reality regarding potential health impacts, especially when they're used outside of medical necessity.
Understanding that reality, the science behind it, feels crucial.
Absolutely. That pull towards rapid physical change is incredibly strong in many communities. Understanding the science, particularly when it involves non-medical high-dose AS use, is vital.
It's not just about the gains, right?
Not at all.
Yeah.
It's fundamentally about the health consequences.
And that's exactly what we're setting out to do today. This is our deep dive into what the science, based on the stack of sources you've brought in, actually tells us about the health effects of this kind of non-medical high-dose AS use.
Yeah, we've pulled together a few key pieces of research to try and build a clear picture.
What kind of sources are we looking at?
Well, there's a pretty comprehensive review of the existing literature. That gives us a broad overview, looks at mechanisms, that kind of thing.
I have a wide view.
Then we have a large prospective observational study, the Harlem study. That one's really valuable because it followed users over time.
So real-world insights, what happens during and after cycle?
Exactly. Gives us a window into that. We've also got a meta-analysis of experimental trials that's particularly useful for looking at specific things like aggression.
Right.
And finally, there's a survey study that sheds light on knowledge and attitudes among a specific group, potential users in this case.
Got it. So our mission today is basically to cut through the noise, the hype maybe.
That's the goal. Unpack these sources, pull out the most important findings.
And try to understand the why behind them, the mechanisms.
Yes, where the sources explain them, and highlight some of the perhaps surprising facts too. The idea is that you, the listener, get a genuinely well-informed perspective straight from the research.
Okay, let's unpack this then. So starting right at the beginning, what exactly are anabolic-androgenic steroids, AS? What does that mean chemically?
Right. So at their core, AAS are synthetic versions or derivatives of testosterone.
The main male hormone.
Exactly. Testosterone is the main naturally occurring androgen. These synthetic compounds are designed to mimic its effects, specifically the anabolic effects, tissue growth, especially muscle, and the androgenic effects, which are linked to male characteristics.
And the sources make a really clear distinction between using them medically and, well, what they call abuse or non-medical use. Can you break that down?
Yeah, that's a critical starting point. There are definitely legitimate medical uses for testosterone.
Like for low T?
Precisely. Standard treatment for male hypogonadism, where the body isn't producing enough, usually given as esterified forms like testosterone, enanthate, or cypionate, for slower release.
Okay.
And then there are a few other specific AS like nandrolone or oxandrolone, which have very limited medical uses, maybe severe osteoporosis, certain types of anemia, conditions where you need to stimulate red blood cells or build tissue.
But that's all under doctor supervision, right? Careful dosing.
Absolutely. Therapeutic levels, careful monitoring, aiming to restore normal physiological function.
Which is totally different from what we're focusing on today.
Completely different. Our focus, as laid out in these sources, is the non-medical use. This means taking doses that are often, many, many times higher than those therapeutic levels.
And the goal is different too.
Right. Primarily for rapid muscle gain, strength increase.
Yeah.
For appearance or maybe athletic performance. When we say AS use today, this is the context. High dose, non-medical.
And even though it's outside medical channels, often illegal to buy and sell, the research suggests it's more, surprisingly common.
Oh, it's far from niche. The estimated global lifetime prevalence is pegged around 3.3%.
Which sounds maybe not huge, but...
But then you look specifically at males, and that figure jumps to 6.4%. That's millions of men worldwide who've used AAS non-medically at some point.
Wow. And how are people getting them?
Typically illicit channels, according to the sources, dealers, online sources. The legality varies, but often the trade and sometimes the use itself is illegal.
And this prevalence means doctors are likely seeing these users.
Highly likely. Any practicing physician probably has patients who are current or former users, whether they disclose it or not. It's just statistically probable.
Okay, so since they're synthetic testosterone versions, how do they actually get into the body and work? The sources mention differences between injections and orals.
Right, let's break down those routes. Injection is very common. Usually the AS is dissolved in oil.
Like sesame oil or something?
Could be. Often with things like benzoate or benzyl alcohol added to keep it dissolved and sterile. You inject it into a muscle.
And it just sits there.
Pretty much. It forms an oil depot. The steroid then gradually diffuses out of that oil into the muscle tissue and then into the bloodstream.
So it acts like a slow release system.
Exactly. And the speed of that release is heavily influenced by something called esterification.
Esterification.
What's that? It's a chemical modification. They attach a specific carbon chain, an ester group, to the steroid molecule. This makes the steroid more fat-soluble, slowing down how fast it leaves that oil depot.
Ah, so it controls the release time.
Precisely. Think about plain testosterone. Inject it by itself, its half-life in the body is maybe only 10 minutes, gets metabolized super fast.
Practically useless then.
For injection, yeah. But attach a short ester, like propionate 3 carbons, and the half-life jumps to about a day.
Okay.
Attach a longer one, like an anthate 7 carbons, and now you're looking at a half-life over 4 days.
That makes a big difference for dosing schedules.
Huge difference. And once that esterified steroid gets into the blood, enzymes called esterases just chop off the ester group, releasing the active, unmodified steroid. The injection site and volume can also play a small role in absorption speed.
Okay, that covers injections.
Right.
What about the oral steroids? How do they work?
For an oral AS to be effective, it has to survive its first trip through the liver after being absorbed from the gut. The liver is really good at breaking down substances like this.
The first pass metabolism.
Exactly. So to get around that, oral AS often undergoes a specific modification called 17-alpha-methylation. This structural tweak makes the molecule resistant to being broken down by the liver.
So more of the active drug gets into circulation?
Right, but the sources emphasize this 17-alpha-methylation is strongly linked to liver toxicity, hepatotoxicity.
Ah, the trade-off again. Oral convenience versus liver risk.
That seems to be the case. You get bioavailability, but at a potential cost to the liver.
So once these AAS, injected or oral, are in the bloodstream, how do they get to the muscles or other target tissues?
They mostly travel bound to proteins in the blood plasma.
Not just floating free.
Mostly not. The main carriers are albumin and, importantly, sex hormone-binding globulin, or SHBG. Under normal conditions, only a very small percentage, maybe 1% to 4% of testosterone, is unbound or free.
And that's the important part, the free fraction.
Generally, yes. That free fraction is thought to be the part that can easily slip into cells and actually exert its biological effects.
Okay, so it gets into the cell. Then what? How does it actually trigger muscle growth, for example?
The primary mechanism involves the androgen receptor, or AR. Since ASS are lipid-soluble, they can pass through the cell membrane pretty easily, usually by simple diffusion.
Inside the cell?
Inside the cell, the steroid molecule finds and binds to its specific partner, the androgen receptor. This binding changes the receptor's shape.
Like a key in a lock.
Sort of. It causes the AR to let go of some chaperone proteins it was holding onto, and then it moves or translocates into the cell's nucleus.
Where the DNA is.
Exactly. In the nucleus, 2 of these activated AR steroid complexes pair up. They form a homodimer. This pair then finds specific sequences on the DNA called androgen response elements, AREs.
Near the genes they control.
Precisely. Binding to these AREs acts like a switch. It ramps up or sometimes ramps down the transcription of those target genes. And that's how AR ultimately influence things like muscle protein synthesis.
But the sources also mention some effects that don't involve this whole DNA binding process.
Right. Those are often called non-genomic effects. They happen much faster and don't rely on that classic pathway of changing gene expression via the AR in the nucleus.
How they work then?
It's thought they might involve other receptors located on the cell membrane or maybe signaling pathways within the cytoplasm. The sources mention one potential candidate receptor, GPRC6A.
Okay.
But they also quickly add that the specific clinical effects driven by these non-genomic pathways are still pretty unclear. It's an area needing more research.
And the body doesn't just let these substances hang around forever, right? It modifies them.
Yeah, through metabolism. There's bioactivation and inactivation. A key example of activation is testosterone getting converted into dihydrotestosterone, or DHT.
By that 5-alpha reductase enzyme, the one involved in hair loss.
That's the one. DHT is actually a more potent androgen in certain tissues, like the prostate and skin. But interestingly, one source specifically highlights a study using dutasteride, a potent inhibitor of that enzyme.
Uh-huh.
And it found that blocking the conversion of testosterone to DHT didn't seem to lessen the increase in lean muscle mass you get from testosterone.
So DHT isn't the driver for muscle growth from testosterone.
It appears not, based on that finding. Crucial for some androgenic effects, yes, but maybe not the primary muscle-building effect of testosterone itself.
What other conversions happen?
Testosterone can also be converted into estradiol, an estrogen, by the enzyme aromatase. This is really important because that conversion is linked to side effects like gynecomastia, male breast enlargement.
Right, and inactivation.
Once they've done their job, most LES are primarily broken down and inactivated, mainly in the liver, but other organs like the kidneys play a role too.
Okay, so putting all this extra powerful hormone into the system at these high doses, that must seriously mess with the body's own natural hormone production.
Oh, profoundly. And this leads us to probably one of the most critical systemic effects: suppression of the hypothalamic pituitary gonadal axis, or HPGA.
The body's internal thermostat for hormones.
Exactly. It's the feedback loop. Hypothalamus makes GnRH, tells the pituitary to make LH and FSH. LH tells the testes in men to make testosterone. FSH is vital for sperm production.
Right.
When you flood the system with high-dose external AAS, the brain and pituitary sense these super high androgen levels. They basically say, whoa, way too much hormone here, and shut down their own production of GnRH, LH, and FSH.
So the signal to the testes just stops.
Pretty much. This slams the brakes on the testes' natural testosterone production and their ability to make sperm. This HPGA suppression is absolutely central to understanding many of the reproductive and endocrine side effects we need to talk about.
Got it. Okay, so we know what they are, how they get in, how they work, and how they disrupt the natural system. Now let's really dig into the effects themselves. The sources seem very clear. Side effects are basically universal.
They really are common. One review cites a prospective study, 100 participants, and every single one reported at least one side effect during their AS use.
100%. Not rare at all.
Essentially guaranteed at these non-medical doses.
And the range of these effects is just huge.
It spans an incredibly wide spectrum, as the sources lay out.
Yeah.
You've got relatively minor cosmetic things like acne,
Uh-huh.
all the way up to potentially life-threatening conditions like cardiovascular disease. If you imagine figure 4 from the review, it breaks it down nicely. Dermatological, cardiovascular, liver, kidney, psychiatric, musculoskeletal, reproductive, endocrine.
It touches almost every major system in the body.
Pretty much. And the likelihood of getting any specific side effect varies a lot, of course.
Yeah.
Depends on the drug, the dose, how long you use it, individual factors.
Makes sense.
But taken together, the data clearly shows a broad and common impact on health.
Okay, so let's dive deeper into some of these specific areas, pulling out the details from the sources. Maybe start with some of the more visible cosmetic type effects, like acne.
Yeah, acne vulgaris, definitely a frequent report.
Yeah.
The Hurlem study looked at this specifically, following users over time.
What did they find?
They found that the percentage of subjects reporting they had acne jumped significantly. It went from 10% before they started their cycle up to 52% by the end of it.
Wow, quite a jump.
But here's an interesting wrinkle. When the physicians in the study actually looked at the participants' skin, did a physical exam, the increase was still there, but it was less dramatic. It went from 13% visually confirmed acne at baseline to 29% at the end of the cycle.
Huh. That's a big difference between self-report and what the doctor saw. Why the gap?
The review suggests a couple of possibilities. One is that users might just classify any minor pimple or breakout as acne, leading to higher self-reporting.
Okay.
The other thing is the visual check by the doctor only happened at one specific time point at the end of the cycle. It might have missed periods earlier in the cycle when acne was maybe worse.
Right. Timing could matter.
Definitely. But either way you slice it, self-reported or observed, there's clearly a significant increase in acne during high-dose ACE use.
Okay. What about another common concern, hair loss? Is the evidence strong there?
This is actually one of those areas where the sources present something a bit surprising compared to, common gym lore. They actually note a lack of strong, high-quality evidence directly linking ACE use to hair loss in the literature they reviewed.
Really? Because you hear about it all the time.
Exactly. They point out there can be confounding factors like sometimes users take other substances concurrently, maybe thyroid hormone, which could influence hair loss itself. Makes it hard to pin it just on the AS.
But users definitely try to prevent it while on cycle, right?
Oh, absolutely.
Yeah.
Self-medication is widespread. People use topical minoxidil, or they might take oral 5-alpha reductase inhibitors drugs like finasteride or dutasteride.
The ones prescribed for male pattern baldness?
Precisely.
Yeah.
But the sources express some serious skepticism about how effective those 5-alpha reductase inhibitors actually are in the context of high-dose AES use.
Why wouldn't they work? They block the conversion to DHT, which is the hair loss culprit, right?
They do block that conversion, and they work when you have normal endogenous testosterone levels.
Huh.
But think about it. When someone's taking superphysiological doses of AES,
The levels are just sky high.
exactly, the sheer amount of circulating androgens might just overwhelm or compensate for any reduction in DHT you get from the inhibitor. Plus, many common AJS compounds, like stanozolol or oxandrolone, they're already 5-alpha reduced, or they don't really interact with that enzyme significantly anyway. So inhibiting it wouldn't affect their potential impact on hair.
Ah, so the drug wouldn't even target those specific ADS.
Right. The review does note nandrolone is an interesting exception. It is converted by 5-alpha reductase, but to something called dihydronandrolone DHN, which is actually less androgenic than nandrolone itself.
So blocking that conversion could actually make nandrolone more androgenic?
Theoretically, yes. Finasteride could potentially increase nandrolone's androgenic effects by stopping it from becoming the weaker DHN. But the clinical significance of that isn't really clear. Overall, though, the sources suggest relying on these inhibitors to prevent hair loss while blasting high-dose AGS is probably, well, unlikely to be very effective.
That is a surprising nugget. Common belief versus the evidence in the sources. Okay, let's shift to another specific issue. Virilization in women.
Yes, this is a really critical point. The sources emphasize that virilization, the development of male physical characteristics, can happen quite easily in women using AES, sometimes even at doses considered relatively low compared to what men use.
And what kind of effects are we talking about?
Specific effects mentioned include dysphonia, that's a deepening of the voice.
Voice changes, even at low doses. Can you give an example?
Yeah, the review cites a study in postmenopausal women. They were on standard hormone replacement, but one group also got just 50 milligrams of nandrolone decanoate every 4 weeks.
Which doesn't sound like a huge bodybuilding dose.
Not at all, but compared to the women just on HRT, this group reported more voice issues. And an objective acoustic analysis actually showed changes, loss of high frequencies, lower average speaking pitch.
Wow. So the voice box is quite sensitive.
Seems to be. And those changes can be permanent, even from what seems like a relatively low androgen exposure in that context.
What other virilizing effects are mentioned?
Hirsutism, that's excessive body hair growth in a male-like pattern, that's common. And also clitoromegaly, which is enlargement of the clitoris.
Is that also dose-dependent?
It seems so. The sources mention studies looking at different testosterone doses in women, and the suggestion is that clitoromegaly requires a higher threshold of androgenic action compared to, say, voice changes or hirsutism.
Yeah.
You likely need a higher dose or maybe a more potent androgen to cause significant clitoral enlargement.
Okay, let's pivot from those effects to potentially more serious impacts. Cardiovascular and hematological effects. Starting with erythrocytosis, that's an increase in red blood cells.
Yes, this is a very well-documented effect of SGA. The mechanism described in the sources is basically that SDAs seem to nudge the body's set point for erythropoietin and hemoglobin higher.
Erythropoietin, that's the hormone from the kidneys signaling red blood cell production.
Correct. And SD also appear to suppress hepcidin. Hepcidin is a hormone that normally limits iron absorption from the gut.
So suppressing hepcidin means more iron gets absorbed.
Exactly. More iron available for making red blood cells. That combination, stimulating production and increasing the building blocks, leads to an increased red blood cell mass.
Is this dose-dependent?
Yes, it seems to be. It becomes particularly noticeable with testosterone and enanthate doses above, say, 300 milligrams per week. And interestingly, the effect seems more pronounced in older men compared to younger men.
How big are these increases we're talking about?
The sources give some numbers. One study with healthy young men using 600 milligrams of testosterone and enanthate weekly for 20 weeks saw hemoglobin go up by 1.4 grams per deciliter.
Okay.
In older men, same dose, same duration, the increase was more than double that 2.9 grams per deciliter.
And how does that translate to hematocrit, the thickness of the blood?
Roughly, those hemoglobin increases translate to about a 4 percentage point rise in hematocrit. And the sources note it can take several months for these levels to really stabilize after someone starts high-dose testosterone.
Does blocking that conversion to DHT make a difference here, like with the hair loss inhibitors?
Doesn't seem like it. Based on the sources, studies using finasteride or dutasteride alongside testosterone showed no impact on the hemoglobin increase. So The erythrocytosis seems driven by testosterone itself or other non-5A reduced androgens, not specifically DHT.
Okay, so more red blood cells means thicker blood. That logically raises the risk of blood clots, right? Is that link solid in the research?
That's a absolutely critical concern. Higher hematocrit increases blood viscosity, which is a known risk factor for clots. The sources discuss findings from two big Danish cohort studies looking at this link with VTE, venous thromboembolic events.
Things like DVT or pulmonary embolism.
Exactly. The first one, the TROMSET study, found a clear positive association. For every 5 percentage point increase in hematocrit, there was a 33% increased risk of VTE in men, even after adjusting for things like age, smoking, and BMI.
Okay, that seems pretty clear. What did the second study find?
The second one, the Copenhagen General Population Study, focused specifically on men with really high hematocrit in the top 5% of the population. But this study found no statistically significant link between being in that top 5% and the risk of VTE.
Huh. That's contradictory. One says yes, one says no. How do the sources explain that discrepancy?
They float a couple of ideas. The Copenhagen study adjusted for more variables in their analysis, things like alcohol use, overall health status, use of antiplatelet drugs, on top of age, smoking, and BMI.
So maybe those extra factors explained away the risk.
It's possible. The other suggestion is maybe one of the studies just didn't have enough statistical power to reliably detect an effect. They point to the wide confidence interval around the VTE finding in the Copenhagen study. So maybe the link is there, but they just couldn't definitively prove it in that specific group.
What about clots on the artery side? Heart attacks, strokes?
The Copenhagen study looked at that too. They found no link between being in that top 5% hematocrit group and arterial clots in the brain. So stroke risk wasn't increased. But they did find a significantly increased risk of arterial thrombosis in the heart, basically. Heart attacks for those men in the top 5% hematocrit range.
So high hematocrit linked specifically to heart attack risk in that study, but not stroke or VTE. Interesting nuance.
It is. Highlights the complexity.
Okay, moving to another major cardiovascular risk. Hypertension, high blood pressure. Does ASUs push blood pressure up?
Yes, the Harlem study gives us pretty solid prospective data on this. They saw an average increase of 7 mmHg in systolic blood pressure.
The top number.
Right, and 3 mmHg in diastolic, the bottom number, during an AS cycle. And maybe more importantly, 41% of the participants in that study met the criteria for hypertension while they were on cycle.
Nearly half became hypertensive. That's significant.
It's a very high percentage.
Sure.
Now, the slightly better news from Harlem was that these blood pressure levels did return to baseline 3 months after the subjects stopped their cycle.
So potentially transient for many, but still a period of high BP. And we know chronic high BP is bad long term.
Absolutely. The sources really emphasize the potential impact by flipping the stats.
Yeah.
We know from studies on BP-lowering drugs that dropping systolic by just 10 mmHg cuts major cardiovascular events by 20%, stroke by 27%, heart failure by 28%, and overall death by 13%.
So logically, raising it by a similar amount, even temporarily,
likely carries the inverse risk during that period of elevation.
Yeah.
It certainly underscores the importance of monitoring blood pressure in users.
And the sources bring up a fascinating, very practical point for doctors measuring BP in these individuals related to muscle mass.
Yeah, this is a great clinical pearl from the review. AACs users, especially bodybuilders, often have very large upper arms. Using a standard-sized blood pressure cuff on a very muscular arm can artificially inflate the reading.
Give a falsely high number.
Significantly so. They cite a study in competitive bodybuilders. For those with an arm circumference over 33 centimeters, using a medium cuff gave a systolic reading that was 8.2 mmHg higher on average, compared to using the correct large cuff.
Wow, 8 points just from the wrong cuff. That could easily push someone into the hypertensive category incorrectly.
Exactly. In that study, 33% were classified as hypertensive with the smaller cuff, but only 12% were actually hypertensive when measured with the properly sized large cuff.
That's a huge potential for misdiagnosis or unnecessary treatment.
It really highlights why using the right equipment is crucial for accurate assessment in this specific population. Thankfully, the Harlem study did adjust for arm circumference and used appropriate cuffs, so their finding of that 73 mmHg increase is considered reliable.
If someone does need BP medication while using Alias, do the sources suggest any particular types might be preferable?
They mentioned sort of theoretically that ACE inhibitors or ARBs might be a better choice.
Why those?
Because they generally don't seem to have negative effects on lipid profiles or cause other problematic interactions compared to some older classes of BP meds. However,
big caveat coming.
Big caveat. The sources are very clear. No dedicated clinical trials have actually tested the effectiveness or safety of any blood pressure medication, specifically in high-dose AOS users. So it's really based on clinical judgment and extrapolating from other patient groups.
Okay, let's shift from blood pressure to blood fats lipids, dyslipidemia. How does ASG use affect cholesterol and triglycerides?
Generally speaking, AS tend to cause an unfavorable shift in the lipid profile. The most consistent effect is on HDL cholesterol, so-called good cholesterol.
It goes down.
Yes. Injectable AS typically decrease HDL-C, although the sources do mention nandrolone might be an exception, having less impact there. But oral AS,
Worse again.
consistently worse.
Yeah.
Oral AS cause moderate to large decreases in HDL-C, and this happens even at relatively low doses.
Why are the orals so much harder on HDL?
The hypothesis put forward relates back to that 17-alpha methylation needed for oral bioavailability. This modification means the drug survives the liver's first pass, leading to higher concentrations interacting directly with liver cells.
More liver exposure, more HDL impact.
That's the thinking. This increased hepatic exposure is thought to be why orals hit HDL harder than injectables. The Harlem study confirmed this pattern too. HDL-C dropped during use, came back up after stopping, and the oral users generally had worse lipid profiles overall.
Is there a proposed mechanism for how AOS lower HDL?
The main one discussed is an increase in the activity of hepatic lipase, or HLE. This enzyme sits in the liver and helps break down HDL particles.
So more HL activity chews up HDL faster.
That's the idea. But the sources add a note of caution, saying the evidence suggests this increased HL activity is probably only partly responsible. Other contributing factors aren't fully nailed down yet.
Now here's a really interesting question the sources raise. Does lowering HDL-C automatically mean a higher risk of heart disease?
This is where things get nuanced, and the science is still evolving. We know low HDL levels are consistently associated with higher CVD risk. But is the low HDL causing the risk, or is it just a marker of something else going on?
The causality question.
Exactly. The sources point to the big, disappointing trials of CETP inhibitors. These were drugs specifically designed to raise HDL levels.
Hoping to reduce heart disease.
Right, but they failed. Raising HDL pharmacologically didn't translate into fewer cardiovascular events.
So just tweaking the number isn't the whole story.
It suggests not. And conversely, the sources say just lowering HDL levels with AOS might not automatically mean increased risk, though they quickly add that it may well be the case that it does contribute. It's complex.
So maybe it's less about the amount of HDL and more about how well it's working, its function.
That's precisely the direction some research is heading. They discuss something called cholesterol efflux capacity, or CEC.
CEC.
It's a measure of how effectively HDL particles can actually pull cholesterol out of cells, particularly those foam cells in artery plaques, kind of like HDL's garbage truck function.
Okay. And how does HEAAs affect this function?
Here we see another split based on dose type. Studies looking at standard testosterone replacement therapy, TRT, at physiological doses generally find no change in CEC.
So normal levels are okay for function.
Seems so. But cross-sectional studies looking at people who've used high-dose AS for long periods have found impaired CEC compared to non-users. Their HDL just doesn't seem to work as well.
Why the difference between TRT and AAS abuse studies?
The sources suggest a few reasons. It could be the much higher doses in non-medical use, the sheer variety of different LAS compounds people use, not just testosterone, or even differences in how CEC is actually measured in the lab across studies. Lots of variables.
Okay, that's HDL. What about LDL cholesterol, the bad kind?
For LDL, injectable AS generally seem to have little to no significant effect on levels.
So injectables spare LDL.
Mostly, yes. But following in the pattern, oral AS do consistently cause a significant increase in LDL-C. The Harlem study also observed this LDL increase during AS use.
So oral AS seem problematic for both HDL down and LDL up, a double whammy.
That's the general picture for dyslipidemia painted by the sources. Now there's one more player, lipoprotein or LPA.
LPA. I know high levels are considered a risk factor for heart disease.
A causal risk factor, the sources emphasize. Elevated LPA is now pretty well established as directly contributing to CVD risk. But here's the twist. L of S seem to have either a neutral or sometimes even a favorable effect on LPA. They often cause a decrease in LPA levels.
A positive effect. That seems counterintuitive given everything else.
It does sound like a silver lining, but the sources immediately pour cold water on that idea.
How so?
They stress that an LES-induced drop in LPA should not be seen as balancing out or canceling the other negative cardiovascular effects, especially because only about 15–20% of the population actually has genetically high LPA levels to begin with. For the majority of users who start with normal LPA, lowering it further probably doesn't change their overall risk profile much compared to the negative hits on HDL, LDL, blood pressure, etc.
Right, it doesn't negate the other bad stuff. Do users try to manage these lipid changes themselves? With supplements or anything?
Oh yes, self-medication for lipids is common. People try dietary supplements, niacin, red yeast rice extract, berberine are mentioned. Sometimes they use prescription statins obtained illicitly or otherwise.
Do the sources comment on whether these things work?
They briefly touch on the evidence. Niacin does raise HDL, but big studies haven't shown it actually reduces overall mortality.
So it changes the number, but maybe not the...
Seems like it. Red yeast rice contains compounds chemically similar to statins, specifically lovastatin, but the actual amount can vary hugely between different products, making it unreliable.
What about berberine?
Some studies show it can lower LDL, but the sources describe the quality of those trials as generally poor. Plus, they warn about potential drug interactions with berberine, as it can affect liver enzymes involved in drug metabolism.
And statins?
Statins are the standard medical treatment for high LDL, and they are effective. The main issue discussed is user-intolerant side effects like muscle aches. Sometimes switching statins, lowering the dose, or using alternative dosing schedules like every other day can help manage that. Other options like ezetimibe or PCSK9 inhibitors are mentioned as possibilities for those who really can't tolerate statins.
Okay, that covers the blood chemistry pretty thoroughly. Let's move to the heart muscle itself. Cardiomyopathy damage to the heart muscle? What do the sources say happens there?
They describe a pattern of structural and functional changes in the heart associated with AAS use. One common finding is concentric left ventricular hypertrophy.
Meaning the main pumping chamber walls get thicker.
Exactly. The walls of the left ventricle thicken. You can also see a decrease in left ventricular ejection fraction, or LVEF.
That's how much blood the heart pumps out with each beat, a measure of efficiency.
Right. Lower LVEF means less efficient pumping. They also report impaired relaxation and filling of the ventricle. This shows up on echocardiograms as changes in ratios like EA or EM, and a longer isovolumetric relaxation time, IRT.
Suggesting the heart muscle is getting stiffer?
Essentially, yes. Less compliant, doesn't relax and fill as well. Overall, the picture's often increased left ventricular mass and sometimes an enlarged left atrium as well.
Are there specific studies showing this?
Yes, the sources mention earlier studies using standard 2D echo, like those by Naughton and Krieg, which consistently found impaired relaxation in 2S using bodybuilders. The Harlem study, being prospective and using more advanced 3D echo,
Gave even clearer data.
It provided really valuable longitudinal data. They found LVEF dropped by an average of 5 percentage points during the cycle.
Wow.
They saw increases in chamber sizes and wall thickness. And that EA ratio decreased, confirming that diastolic dysfunction or stiffness.
So, definite negative changes to heart structure and function while people are using A's. The massive question then is, are these changes permanent? Do they stick around after stopping?
This is a really crucial and maybe somewhat surprising finding from that Harlem study.
What did they find at follow-up?
They followed participants for 8 months, which included the cycle and then a recovery period afterwards.
Yeah.
They observed that all of the cardiac parameters they measured, LVEF, the sizes, the thickness, the EA ratio, had actually returned to baseline levels by the end of that 8-month follow-up.
All of them. Back to normal.
Back to baseline, according to their measurements in that study timeframe.
That points pretty strongly towards reversibility, at least for that duration of use and follow-up.
It definitely suggests a degree of reversibility, yes. Within that specific context, moderate cycle length, relatively young users, 8-month follow-up.
However,
The caveat. The sources are careful to add the caveat. This finding absolutely does not rule out the possibility that with much more prolonged use, maybe years and years of repeated cycles, these changes could become permanent. We don't know the threshold.
and other studies support the idea that some changes are linked to current use.
Yes, another study mentioned found that impaired LVEF was specifically associated with current AS use and tended to normalize, at least partially, when users were off-cycle. This reinforces the idea that some of these functional deficits might be transient, linked to active exposure.
Are doctors using these heart changes to refine risk assessments for users?
The sources discuss this possibility. Could these AA-induced changes, the hypertrophy, the LVEF drop, be factored in as risk modifiers when using standard cardiovascular risk calculators, like SCORE2 or the pooled covert equations?
To get a better individual risk estimate.
Potentially, yeah. Especially for people who fall into those borderline or intermediate risk categories based on standard factors alone. But the sources acknowledge there isn't solid evidence yet to formally incorporate these specific echo findings into risk algorithms. It's more of an idea under consideration.
So routine heart scans aren't recommended for all users?
Not routinely, no. The evidence isn't there to support mass screening with echocardiography, but the sources say it can still be a very useful tool for clinicians evaluating individuals who have specific symptoms, or if there are particular concerns about their heart health. Figure 6 in the review gives a good visual contrasting a normal heart with that remodeled, thickened wall appearance seen in some AS users.
Okay, let's shift focus now to the reproductive and endocrine systems. This is where that HPGA suppression we discussed earlier really comes into play.
Absolutely. That feedback loop shutdown is central here. High-dose exogenous AS tells the brain and pituitary to stop sending signals, LH and FSH, to the testes.
Which directly leads to the testes stopping their own testosterone production.
Correct. Leading to suppressed natural testosterone. Now, often, after a user stops taking the AS, the HPGA slowly wakes back up and natural production recovers. But
it doesn't always.
That's the issue. The sources mention persistent AS-induced hypogonadism, or ASIH. This means long-term, maybe even permanent, low testosterone levels after stopping AS. This has been reported in case studies.
So recovery isn't a guarantee for everyone.
It seems not. And the sources flag this as a major area needing more research. Why doesn't recovery always happen? Who is most at risk for this persistent low T after stopping? We don't fully know yet.
Users often talk about post-cycle therapy, PCT, using other drugs to try and kickstart their natural production faster. What do the sources say about PCT?
Self-medication with PCT protocols is extremely common. Usually involves drugs like SERMs, selective estrogen receptor modulators like tamoxifen or clomiphene or sometimes HCG, human chorionic gonadotropin.
And does it work? Does PCT prevent or treat this ASIH?
The sources are pretty blunt here. They state that the efficacy of these PCT strategies is largely unproven in the scientific literature. A key issue is that PCT protocols are often very short, just a few weeks.
Not long enough to really assess long-term recovery.
Likely not. And the Harlem study actually looked at this specifically. They compared testosterone levels 3 months after cessation between users who did PCT and those who didn't.
Yeah.
They found no statistically significant difference between the groups at that 3-month mark. They couldn't rule out maybe a very small short-term benefit within that window, but overall, no clear advantage for PCT in restoring testosterone levels long-term in their study.
What about HCG? How is that supposed to work in PCT?
HCG mimics luteinizing hormone, LH. It directly binds to the LH receptors on the Leydig cells in the testes, telling them to make testosterone.
So it bypasses the suppressed brain signals and directly stimulates the testes.
That's the user rationale, yes. They think it jumpstarts testicular recovery.
Yeah.
But the sources raise a potential paradox. By providing this external LH-like stimulation, HCG might actually continue to suppress the brain's own production of LH and FSH. It keeps the negative feedback loop engaged.
So it could be counterproductive for restarting the whole natural axis.
Potentially, yes.
Yeah.
The sources suggest HCG might only be truly helpful in very specific cases where there's evidence of primary testicular problems. But for routine PCT to recover from AAS suppression, the evidence for benefit is limited.
Okay, another huge reproductive consequence is infertility.
Yes, and again, this stems directly from that HPGA suppression. Sperm production, spermatogenesis, absolutely requires LH and FSH acting on the testes. LH triggers testosterone production within the testes, and FSH acts on the Sertoli cells, which are like the nurse cells for developing sperm. When exogenous AA shuts down LH and FSH,
the signals for sperm production stop. But wait, if someone is injecting high-dose testosterone, wouldn't the testosterone levels inside the testes be really high?
This is a super important point the sources clarify. It seems paradoxical. While the circulating systemic testosterone levels are sky high from the injections,
Right.
this high level suppresses LH so profoundly that the testes' own production of testosterone basically flatlines. And normal testosterone levels inside the testes, what's called intratesticular testosterone, or ITT, are incredibly high, like 50 to 100 times higher than blood levels.
Wow. Needs to be super concentrated locally.
Exactly. Those ultra-high local levels of ITT are absolutely essential for driving robust sperm production. When LH gets suppressed by AAS, ITT levels plummet, falling way too low to support spermatogenesis, even though the guy's blood testosterone level is through the roof.
So high T in the blood paradoxically leads to low T, where it matters most for sperm inside the testes. That's fascinating.
It really is. It explains why AAS use is so detrimental to fertility.
It almost sounds like it could be used as a male contraceptive.
It does. And research has explored hormonal male contraception using high-dose testosterone, sometimes with progestins added. But even high-dose testosterone alone doesn't reliably cause complete azoospermia's zero sperm in all men. It works in maybe 2/3. Adding progestins boosts suppression rates.
If someone stops GAS, how long does it typically take for fertility to come back, assuming it does?
The sources cite the Shankar and Ariana study, which tracked recovery times. They found the average time for sperm output to recover was about 14 months. For sperm concentration to recover, it was around 10 months after stopping.
So potentially over a year.
Potentially, yes. And the Harlem study also confirmed a significant drop in average sperm concentration during AS use, with many guys meeting the criteria for oligozoospermia, low sperm count.
Is there a risk this infertility could become permanent?
The sources do mention case reports of permanent infertility after ACE abuse. And a key finding from that Shankar and Ariana study points towards why. They found a strong link between the accumulated duration of ACE abuse, how long someone used for in total, and decreasing levels of inhibin B and AMH. These are hormones produced by the Sertoli cells, those nurse cells for sperm.
So the longer the abuse, the more damage to the sperm factory machinery?
That's the strong implication. It suggests the risk of irreversible damage climbs the longer and more heavily someone uses AS. The Harlem study saw a trend for former users having lower inhibin B, though it wasn't statistically significant, but the sources suggest this could still impact fertility at a population level.
Do they speculate if PCT might help preserve fertility?
They briefly mention, without strong evidence, that maybe PCP could potentially lessen the degree of spermatogenesis impairment, but it's speculative.
Okay, let's talk about erectile dysfunction, ED, another user concern.
Right. Testosterone definitely plays a role in normal erectile function. So ED can be a symptom of low testosterone, like the ASIH that can happen post-cycle.
Makes sense.
But the sources add important caveats. Not every man with low T gets ED. And even when they do, testosterone replacement therapy often only gives a modest improvement in erections. Also, importantly, not every man with ED has low T.
So ED in an AS user isn't automatically because of AAS or low T.
Exactly. That's a key point the sources make. ED has tons of potential causes: psychological, psychogenic, physical, organic, or a mix. While it can happen post-cycle due to HPGA suppression and low T, the sources stress that ED cropping up in an AS user might actually signal an underlying psychiatric issue or relationship problems rather than being a direct hormonal consequence.
How can you tell the difference?
They suggest looking at the pattern: presence or absence of morning-night erections, sudden or gradual onset, intermittent or getting progressively worse. How long has it been going on? Things like having solid morning erections, sudden onset, or intermittent ED often point more towards a psychological cause. Lack of morning wood, gradual worsening, maybe more physical.
What did the Harlem study find regarding ED prevalence?
It was interesting. About 8% reported ED at baseline before the cycle. That went up slightly to 12% during the cycle and peaked at 14% 3 months after stopping. But then it dropped way down to 1% a year after the cycle started.
So a temporary bump post-cycle. Seems like it, but importantly, none of those changes in self-reported ED prevalence reached statistical significance over the whole study period.
Are there other factors besides just low T that might contribute to ED around AS use?
The sources mention a couple of possibilities. Maybe an imbalance between the androgenic effects and the estrogenic effects from aromatization, or psychological factors like the huge libido surge during a cycle causing relationship stress or unrealistic expectations later on.
And users often self-medicate for ED too, right?
Yes, very commonly with PDE5 inhibitors. Prescription drugs like sildenafil, Viagra, tadalafil, Cialis, vardenafil, Avanafil.
How do those work again?
They block an enzyme, PDE5, that breaks down a molecule called CGMP. CGMP is crucial for relaxing the smooth muscles in the penis, allowing blood to flow in and cause an erection. So blocking its breakdown helps achieve and maintain an erection.
Are they generally safe and effective? Yes, they're the standard medical treatment, generally well tolerated and effective for most types of ED. The sources do list the common potential side effects: headache, flushing, indigestion, stuffy nose, dizziness, sometimes transient vision changes, like a blue tinge, especially with sildenafil. And muscle aches are noted more often with tadalafil.
Okay. One more appearance-related effect with hormonal roots. Gynecomastia, male breast enlargement.
Yeah, gyno. It's relatively common, actually. Sources note it happens in puberty, and a fair number of adult men have some degree of it, often minor.
What causes it hormonally?
It's basically an imbalance between androgen and estrogen action on the breast tissue. Either too little androgen effect, or more relevant to AD, too much estrogen effect.
And since many AP can convert to estrogen.
Exactly. Since AAS, like testosterone, can be aromatized into estradiol, the resulting excess estrogen activity is the primary driver of gynecomastia during AA's use.
Users sometimes talk about other causes, like progestins or prolactin.
Yes, those theories circulate in user forums. But the sources largely dismiss them. They point out that androgens typically suppress prolactin, not raise it.
Okay.
And most common, agers have very little activity at the progesterone receptor. Nandrolone might be a slight exception there, but still minimal. Plus, they mentioned a contraceptive study that combined testosterone with a potent progestin. And gyno wasn't reported as a side effect.
So the evidence points squarely at estrogen.
The conclusion of the sources is pretty clear. Excess estrogenic action, mainly from aromatization, is the key mechanism driving gyno in Chase's users.
And how is it managed or treated?
Both doctors and users often turn to anti-estrogen drugs. Two main types: aromatase inhibitors, AIs, which block the actual conversion of androgens to estrogens, and SERMs, like tamoxifen or raloxifene, which don't stop estrogen production, but block estrogen from binding to the receptors in breast tissue. Both are used off-label for gyno.
Okay, let's move into the final section on specific organ impacts. The liver and kidneys, starting with the liver hepatotoxicity.
The key message from the sources here is that significant liver damage is primarily linked to oral AS, not the injectables.
Back to that 17-alpha methylation again?
Seems to be the main culprit. The suspected mechanism involves activating androgen receptors in liver cells, which leads to oxidative stress production of reactive oxygen species, ROS, that damages the cells. Compounds that are resistant to liver breakdown, like the 17-alpha methylated ones, and are potent AR activators are the most likely suspects.
How is liver damage typically monitored?
Often by checking liver enzyme levels like AST and ALT. But the sources caution that these can also go up simply due to intense exercise, which is common in this group. So rises can be hard to interpret.
Are there better markers?
Enzymes like GGT or bilirubin levels are less affected by exercise and might be better indicators, especially for problems with bile flow, known as cholestasis, which can be caused by some orals.
Did the Harlem study see actual liver damage?
Interestingly, despite 2/3 of their participants reporting using oral ACE, the Harlem study found no clinical signs of actual liver damage. Maybe some enzyme fluctuations, but no overt liver disease developed during the study period.
So perhaps subclinical effects in that group, or effects that take longer to manifest?
Possibly. It highlights that while the risk is clearly associated with orals, the clinical manifestation might vary or require longer exposure.
Okay, what about the kidneys? Nephrotoxicity. Is there strong evidence AS damaged kidneys?
Here, the sources adopt a very measured tone. They state quite clearly that there's no good quality evidence indicating that AS use in general causes widespread kidney damage.
So less of a concern than the liver.
Generally speaking, yes, based on the current evidence. However, they do discuss several findings that point to potential issues or complexities related to AS and kidney function.
Like what? What potential issues are raised?
Well, the Harlem study did find small but statistically significant transient increases in serum creatinine levels.
Creatinine. That's the muscle waste product.
Yeah, exactly. And they also saw transient appearance or worsening of albuminuria, small amounts of protein in the urine in some subjects during the cycle. Both of these resolved back to baseline after stopping GA. Another study using a prohormone saw a larger but also transient creatinine spike.
But you mentioned creatinine goes up with muscle mass anyway. How do we interpret that increase in AS users?
This is a really crucial point the sources emphasize, especially for clinicians. Because AA has increased muscle mass, users naturally produce more creatinine each day. This will raise their serum creatinine level, but doesn't necessarily mean their kidney functions, their glomerular filtration rate, or GFR, has actually declined.
So the standard kidney function tests based on creatinine might be misleading.
They can be. Using formulas that estimate GFR based solely on serum creatinine can significantly underestimate actual kidney function in very muscular individuals. It's a major confounder. Also worth noting, Creatine supplementation itself, popular in this group, also raises serum creatinine.
So higher creatinine doesn't automatically equal kidney failure here. But the sources do mention more severe kidney damage in some cases.
Yes, the evidence for more serious, direct kidney injury, like specific scarring patterns called FSGS, focal segmental glomerulosclerosis, or the formation of hyaline casts, comes mainly from individual case reports published over the years.
Not from larger studies.
Primarily case reports. And the sources suggest these severe cases are likely linked to specific circumstances. Extremely high doses, stacking multiple different compounds, and very prolonged durations of use, not necessarily representative of all users.
Is there also a kidney issue linked back to the liver problems?
Yes, something called bile acid nephropathy or cholemic nephrosis. This can happen as a secondary consequence if AS cause cholestatic jaundice, that liver problem affecting bile flow.
So the bile acids back up and potentially harm the kidneys.
That's the idea. Case reports have linked this to various AAS, both oral, like stanozolol, methadrostinolone, oxandrolone, and even some injectables, nandrolone, testosterone, plus others like boldenone and trenbolone. The good news from these reports is that the kidney injury seemed to resolve once the AS were stopped, sometimes requiring temporary support like dialysis.
The sources also describe a really complex, almost paradoxical relationship between testosterone, AAS, and chronic kidney disease, CKD.
They do. It's quite intricate. On one side, having low testosterone or hypogonadism is common in men who already have CKD, and it's linked to worse outcomes for them.
So low T is bad if you have kidney disease.
Seems so. But on the other side, giving external testosterone or AAS can, in animal models and some cell studies, actually worsen kidney injury and accelerate the progression of CKD, potentially by stimulating inflammation, like TNF-alpha, and promoting signaling pathways that lead to kidney cell death and scarring fibrosis.
So too little T is bad for CKD patients, but too much from AS might actively harm the kidneys. That's confusing.
It highlights the complexity and why we need more research. The sources also touch on how AAs might impact kidneys indirectly via blood pressure. Androgen receptors are found in kidney tissue, and AS can potentiate the RAS system and other pathways that raise BP.
Which could strain the kidneys over time.
Right. They cite a study where testosterone worsened hypertension in female rats. Yet, paradoxically again, low endogenous testosterone is also linked to high BP in humans, and giving TRT to hypogonadal men can sometimes lower their BT.
So the relationship between androgens, BP, and kidney effects is just not straightforward.
Not at all. The sources basically say the exact mechanisms are still unknown.
And one last point on kidneys, something about urinary markers.
Yeah, just a methodological note. An experimental study showed testosterone itself can affect how much of certain kidney-related markers are excreted in the urine. This just means researchers need to be careful when interpreting studies that rely on these specific urinary markers, as the AAS use itself could be influencing the marker levels, separate from any actual change in kidney function.
Wow. Okay, that is an incredible amount of detail across so many different systems. It really drives home how widespread the physiological effects of high-dose AS use truly are based on this research.
It paints a very comprehensive and frankly quite sobering picture of the potential impacts.
Let's try and pull some threads together now. A key theme seems to be reversibility. Some effects go away after stopping, others might not. What's the summary there from the sources?
Yeah, it's definitely a mix. On the transient side, we saw those small increases in serum creatinine and albuminuria in Harlem returning to baseline.
Right.
Hypertension also normalized after cessation in that study. And maybe most strikingly, those structural and functional heart changes, LVEF, wall thickness, they also returned to baseline by the 8-month follow-up in Harlem.
So encouraging signs of recovery for some things, at least in the short to medium term. But what about effects that might linger or be permanent?
Well, persistent NDs-induced hypogonadism, ASH, is a documented risk for some individuals. Their natural T just doesn't come back properly. And the risk of permanent infertility seems to climb with the total amount of AS abuse over time, suggesting cumulative damage to the testes is possible.
And the heart, even though it recovered in Harlem.
The sources add that crucial caveat. Just because it recovered after one moderate cycle in 8 months doesn't mean permanent damage couldn't occur with many years of repeated heavy use. The long-term threshold for irreversible change isn't known.
Dose and the specific type of A's also clearly matter hugely for side effects.
Absolutely fundamental. We saw erythrocytosis being dose-dependent, becoming more likely above 300 mg a week of test and anthate. For women, cleromegaly seems to need a higher androgenic hit than voice changes.
And the oral versus injectable distinction kept coming up.
Yes, particularly for liver toxicity, which is overwhelmingly linked to the 17-alpha alkylated orals. And also, for lipids, the orals consistently showed a worse impact on both HDL and LDL compared to injectables in the study cited.
This brings us to a really striking piece of the puzzle from one of the sources that survey looking at user knowledge, the one with physical education students in Palestine.
Yes. That study provides a really eye-opening, and I'd say quite concerning, snapshot. These were young men studying physical education. You might expect them to have some baseline knowledge about performance enhancers and health.
Given their field. And what did the survey find about their understanding of AS side effects?
The results were pretty stark, actually. On a test designed to assess their general knowledge of AS side effects, the average score was only 37 out of 100.
Wow, 37%. That's low.
Very low. And perhaps even more telling, only 10% of them achieved what the researchers defined as satisfactory knowledge, which was getting 80% or more correct.
So 90% of these physical education students had unsatisfactory knowledge about the risks.
That's what the study found, a major knowledge gap. And this was contrasted with their awareness of the perceived positive effects, muscle, strength. They knew the upside they were chasing.
But were largely unaware of the significant documented downsides.
Precisely. They knew the potential benefits, but seemed ignorant of the potential costs highlighted throughout the research we've discussed.
Did the survey look at how many were using or planning to use?
It did. In that specific group, 2.9% said they were currently using AIRAS. Another 7% had used them in the past. And maybe most worryingly, 8% stated they plan to try AS in the future.
And why? What was the motivation?
Overwhelmingly, the main reason given was for bodybuilding and achieving a better-looking physique.
This knowledge gap seems incredibly relevant when you think back to all that self-medication we talked about, users trying PCT or managing lipids or ED on their own.
It's hugely relevant. If the baseline understanding of the primary side effects is so poor, how informed can users possibly be about the actual evidence, or lack thereof, for the effectiveness of all these countermeasures they might be taking?
Right. Are they using things that actually work, or just wasting money, or worse, adding more risk?
Exactly. The sources detail many of these common user practices and then present the scientific evidence, which often shows a major disconnect. That low knowledge score really underscores the potential danger when people experiment with powerful drugs and then other drugs to manage side effects without really understanding the risks or the proven mitigation strategies.
It's clear from everything we've covered that researching this topic properly must be incredibly difficult. What are some of the main challenges researchers face, according to the sources?
They definitely touch on these limitations. A big one is that randomized controlled trials, RCTs, the gold standard for cause and effect, usually have to use much lower doses and shorter durations of TAS than what people use in the real world for muscle building.
For ethical reasons, presumably.
Mostly, yes. The meta-analysis on aggression specifically pointed this out. The doses in research studies often don't match real-world abuse patterns. This makes it hard to directly apply findings from controlled trials to the high-dose, long-term cycles people are actually running.
So the research might not fully capture the effects of real-world use patterns.
That's a significant limitation. Another challenge is the reliance on self-reporting in observational studies, like Harlem, or surveys like the Palestine one. People might not accurately remember or disclose their usage doses, compounds, side effects. Social desirability bias, recall bias,
Makes the data less reliable.
it can introduce uncertainty. Also, cross-sectional studies, snapshots in time, make it hard to know if AS caused a condition or if it was there before or caused by something else. Longitudinal studies like Harlem, following people over time, are better for seeing changes.
Bet they're hard to do.
Much harder. Expensive, take a long time, rely on keeping participants engaged.
And what about studying the really serious long-term outcomes, like heart attacks or early death?
That's where the biggest ethical wall comes up. You simply cannot ethically design an RCT where you randomly assign people to take high-dose Ks for years just to see how many more heart attacks or strokes they have compared to a placebo group.
Absolutely not.
So researchers have to rely on other methods, looking back at records, retrospective studies, analyzing case reports, using data from medical settings, all of which have their own limitations for definitively proving cause and effect for those rare but critical long-term endpoints.
So wrapping this all up, what are the main takeaways for healthcare providers who might encounter AS users in their practice?
I think the sources really emphasize awareness and vigilance. Clinicians need to know that non-medical AS use is prevalent, and they should be looking out for potential side effects across all those systems we discussed: cardiovascular, reproductive, liver, etc.
And understanding those nuances we talked about.
Exactly. Knowing how muscle mass affects creatinine, or why using the right BP cuff size is vital in muscular patients, those are practical, clinically relevant details highlighted by the sources that directly impact patient care. Being aware of the common self-medication practices and the often limited evidence behind them is also key for giving good advice in harm reduction.
And despite this wealth of information we've unpacked, there are still major unknowns, especially about the true long-term picture.
Yes, that's really the bottom line from the main review article. We have a pretty decent handle now on many short-term effects across multiple body systems. But the definitive long-term impact on hard clinical endpoints, cardiovascular events, mortality that remains largely elusive. The huge long-term studies needed are just incredibly difficult to conduct ethically and practically.
This has been an incredibly detailed exploration covering so much ground from these sources. We've gone from how these substances work at a molecular level through this vast array of documented health impacts: skin, hair, heart, blood, kidneys, reproduction. We've seen some effects might be transient, others potentially prolonged or permanent, heavily influenced by dose and type. And maybe one of the most striking threads running through this is that significant gap in knowledge about the risks among the very people using or considering using them.
It really is a complex picture. A potent mix of perceived benefits driving use, set against very real, documented short-term risks, and shadowed by significant long-term uncertainties.
So perhaps here's a thought to leave you, our listener, with, building directly on what we've unpacked from these sources today. Given these well-documented short-term health risks, the persistent uncertainty about the true long-term consequences over years or decades, and the striking lack of knowledge about these risks among many potential users. Why does that powerful pursuit of muscle and strength continue to lead individuals down this path, often without fully grasping the potential costs? What does this fundamental knowledge gap really tell us about how perceived benefits are weighed against understood risks in this specific domain? And what are the broader implications of that gap for public health messages and educational efforts?
Definitely something worth reflecting on.
That's all the time we have for this deep dive. We genuinely hope this detailed walk through the research has provided you with valuable, evidence-based insights directly from the source material.
Thank you for joining us.
We'll be back soon with another deep dive into a complex topic.